Good afternoon, and today I'll be talking about my project that is raising awareness for out-of-hospital recognition and management of brain herniation-related coma. And just a brief introduction about myself. So I'm Alok Dabi. I'm currently the director of the Neurosciences Critical Care Unit at University of Texas Medical Branch, Galveston, Texas. And this project is really close to my heart because I come across many instances where we have patients who have out of hospital brain herniation syndrome and coma related to that. And sometimes the appropriate recognition and management of these patients is suboptimal. So, as many of you may know, the severe brain swelling is fatal if untreated, and nowadays it's called as brain code, and that name was given by the emergency neurologic life support course that is undertaken by the Neurocritical Care Society. And so there are multiple conditions which can give rise to what could be labeled as brain code, which is severe brain swelling. And it could be because of brain trauma, tumor, stroke, bleed, etc. As many of us know, brain injury is the leading cause of disability around the world. And to just kind of give you a little brief statistics, each year, brain trauma leads to 1 million Americans needing emergency department admission. And out of these 50,000 Americans, they end up dying. A little bit more data. So annually, traumatic brain injury leads to 1 million Americans needing emergency department admissions. And out of that, 230,000 people are admitted and they ultimately survive that particular admission. But 80,000 people, they get discharged with some sort of disability. And like I mentioned before, so 50,000 people who end up getting brain trauma because of different reasons, they end up getting, dying. So I really kind of got interested into this, and after a very emotional experience that I had. So about 2 years back, we have a local bike rally every year. And so there was a motorbike driver who presented to the emergency department after a rollover accident because of slippery roads. He did not kind of collide with somebody else. And within minutes of arrival, he developed abnormal clinical signs indicating severe brain swelling. With the help of my team, he was diagnosed appropriately and promptly and was treated appropriately. And ultimately, he survived. So after 6 months, he actually walked into the clinic for his follow-up appointment. But not everybody who undergoes that sort of unfortunate event, they get that chance. And I think, it's very important that we need to change that. So I sort of made it a mission to try and help the paramedics as well as the EMS staff who are typically the first responders to help appropriately recognize these patients, because what they can do before the arrival of these patients to the emergency department can really make an impact on the outcome of these patients. And like I mentioned before, the Neurocritical Care Society has now labeled this condition as brain herniation as the brain code. And as we all know, so a code means time is of critical value, and we all know that time is brain. So appropriate recognition, treatment, and transfer of these patients, they can really make an impact on thousands of these patients and all the millions of family members who are associated with them. So for the neurologists and the physicians in the audience, so what I would like to say is that we need to pay attention to some of these presenting findings, which may help us recognize appropriately what could be a brain code situation. So the symptoms are typically headache, nausea, vomiting, and impaired consciousness. Now, if you see this triad, particularly in the history, then that would be indication to try and look into a detailed neuroexamination. And there are certain specific signs that I'll be talking about which can help us appropriately recognize these kind of patients. So whenever you see this triad of headache, alternate mentation with nausea and vomiting, then it's important that we do a focused, quick neuro exam, which involves looking for posturing, which could be flexor or extensor posturing. And I have some pictures to help you easily recognize those findings. Then looking at the brainstem reflexes, particularly the pupils, extraocular movements or eye movements with head rotation, corneal reflex, which is basically touching the cornea, and checking for gag and cough reflex. Irregular breathing, when it is present, it may be a sign suggestive of a brain code, and there may be presence of motor weakness, which could be ipsilateral or bilateral. So these are the different breathing abnormalities. The one which are in the red box, they are the ones which are suggestive that the patient may be having an underlying brain herniation or a brain code situation. The common brainstem reflexes that need to be checked include pupillary light reflex. We all know that pupils, they should constrict normally and equally when there is light shown upon them, and that should happen bilaterally. Corneal reflex, when you touch the cornea with the help of a cotton vesp, then there should be a blink response, which is equal and symmetric. Similarly, cough reflex on stimulation of the airway, and typically that is done with the help of the suction catheter, because the first step would be ABCs for managing these kind of patients, and very likely these patients would already be intubated, and they usually have a suction catheter. With the help of that, you can check the cough reflex. The presence of altered sensorium or altered mentation, it's a sign we already talked about in the history. Irregular eye signs, so if the pupils are unequal in size, that's an adverse prognostic sign. And if the gaze is forced to one side, or if the gaze is forced downwards, like in this picture over here, again, that's a adverse sign. Presence of nausea and vomiting, we already talked about that in the symptoms. And motor weakness could be bilateral, it could be ipsilateral or unilateral, with the associated signs that we talked about, may be suggestive that there could be a brain code situation. Headache, we mentioned that, and this is the picture suggesting, what could be decorticate or what we call as flexor posturing, as well as decerebrate or the extensor posturing. So both of these posturing reflexes, they are suggestive that there's a significant injury to the brain with very high risk for concern for brain herniation syndrome or brain code. So that needs to be treated emergently. So I made an acronym out of it, and that is a brain map. And we kind of, just to kind of recap. So presence of breathing abnormalities, reflexes when they're absent, altered mentation, irregular eye signs, nausea and vomiting, motor weakness, headache, and posturing. So if the first responders, they come across this, then the next step would be to rush. And so that is recognize that this is a brain code which warrants urgent action. And the immediate simple things that need to be done would be to straighten the neck and keep it in midline. Of course, there could be associated C-spine injury, so that needs to be taken care of at the same time. And to try and initiate hyperosmolar therapy and maybe hyperventilation, particularly if there's end-tidal volume CO2 monitor available. So this was my presentation, and if you have any questions, then you can contact me. Thank you.